Hello friends, so welcome to yet another edition of Sunday 5 Physiology Live. Let's deep dive into the concepts of physiology. Let me make 2 points here. First point, who is this useful for? ये किसके लिए ये useful है ये sessions? Oh, 1 minute.
Welcome to yet another.
Okay. This session is useful for the first prof students, first MBBS students, but it is also useful for second year, final year students who are preparing for their PG entrance exams. It could be NEET-PG or NEXT or USMLE or PLAB, FMGE students. So this is useful for any student of medicine, point number 1, because physiology comes in every other subject of medicine. So more you learn, more it is useful for your various other subjects of medicine. That's the point number 1. And second point is why live? I have answered this question. The live means you allocate that time for a concept learning. So compulsorily you attend and your concept is done. So mainly, although the subject physiology is for the first prof, for the exam point of view, those who are attending, the first year students who are attending, they will get a lot of physio plus concepts for their first year exams to get extra marks in their exams. So having said all this, now let's start our today's topic, and that is equal pressure point, the concept of equal pressure point. This is normally not taught at the first year level, and it is required in the medicine in the context of COPDs. So let me start by saying what is the application of this concept in medicine, in the applied physiology or medicine. There is a category of diseases called as COPDs, chronic obstructive pulmonary diseases. By now, even if you are a first year student, you must be aware that it's a obstruction to the airways, and the examples like bronchial asthma or chronic bronchitis, there is narrowing of the airways. Airways are edematous, inflamed, constricted and narrowed. So what is the typical breathing in such diseases, and what is the role of this equal pressure point in the disease, in their diseased breathing? That is going to be the application of this concept, and therefore without much ado, let's start today's discussion on the equal pressure point. I will start with the basics, and then we will develop this concept. So the basic points, you are probably aware of these points. There are generations of the respiratory tree. There are starting with trachea, and then as the trachea divides into right and left main bronchus, then they further divide and divide and divide. Every time the respiratory passage divides, it's a new generation. So remember, trachea is the 0th generation, obviously, because it has not divided yet. So trachea is taken as the 0th generation. Then first time it divides into right and left main bronchus, so that's first generation. And then the second generation, then the third generation. That is how our respiratory passage divides 23 times. So there are 23 generations of the respiratory tree. All right. That's point number 1. What is more important for us to understand is that trachea and the first 7 generations are cartilaginous. That is, they have cartilage in their walls. You can see here, I have drawn it diagrammatically. I have not shown 23 generations, but just as a representative diagram, you can see here that there is cartilage in the wall of these airways. Which airways? Trachea and the first 7 generations. We can call it upper airways. The lower airways, that is last 16 generations, they are mainly the intrapulmonary airways inside the lungs, and they have no cartilage, but they have thick smooth muscle. But the point is, no cartilage in last 16 generations. What is the importance of knowing this? The importance is last 16 generations, the lower generations like bronchioles and terminal bronchioles, etc. These are prone for compression. Note this point here, that the first 7 generations leave trachea because it is anyways the most upper part of the respiratory passage. It's not inside the lungs, so it's not going to be compressed. But first 7 generations, some of them are inside the lungs and still they are non-collapsible or non-compressible. First 7 generations. Why? Because they have cartilage, a semi-bone type structure, cartilage in their wall, and because there is a cartilage, that cartilage holds the airway. It provides a tethering effect, and therefore first 7 generations, although some of them are inside the lung, they cannot be compressed, do not get compressed. Whereas the last 16 generations, the lower generations towards the alveoli, they don't have cartilage in their walls, and because of that they are very much compressible. Having taken this point, now I'll proceed to the next level of this discussion. This is a normal physiology which you should understand, that first 7 generations, the upper airways, they have cartilage in the wall. Last 16 generations, no cartilage in the wall. That means they are prone for compression, and they are prone for compression especially during expiration. Especially during expiration. Why is that? Because when we inspire, the negative intrathoracic pressure will open up the lungs and pull open the airways. So airways are not getting compressed. But when we exhale out, when we are expiring out the air, there is recoil of the lungs plus the positive intrathoracic pressure, and therefore these lower generations are prone to certain amount of compression. So that is the normal physiology, and now let's go to the next level of this discussion. The concept of equal pressure point. The concept of equal pressure point. Look, I'm talking about the pressure inside the airway and the pressure just outside the airway. We are here talking about the pressure inside the airway and the pressure just outside the airway, and we are comparing these two. Okay, so at some stage there is going to be equal pressure. What is equal pressure? What does it mean? Inside the airway, pressure inside the airway and pressure just outside, that is interstitial pressure. These two pressures will be equal. That point we are referring to as equal pressure point. Let me explain it further. यहाँ पे और एक थोड़ा सा explanation दे दूं. Let's say this person has taken a deep forceful inspiration. Now I am telling you the explanation of the definition equal pressure point. This person has taken a deep forceful inspiration. The lungs are distended. And now the person starts a forceful expiration. So imagine that starting point. Have you imagined this? Maximum inspiration taken. Now start thinking that the person is now going to take deep expiration, forceful expiration. Now imagine the starting point. Since there is going to be a forceful expiration, the intra-alveolar pressure at the start of that expiration is going to be plus 20 centimeters of water. I am taking an arbitrary figure. Look, in normal quiet breathing, the intra-alveolar pressure at the start of expiration, it is +1, and because it is +1, the air is expelled out. But now we have talked about maximum inspiration followed by forceful expiration. So there is going to be compression of the thoracic cage and the recoil of the alveoli and recoil of the lungs. So naturally the intra-alveolar pressure will be much more positive. It's in the range of plus 20 centimeters of water. Also note that in the entire interstitium, see, outside the airway there is interstitium and everywhere the pressure is same, that is plus 6, okay, plus 6 centimeters of water. I have taken some arbitrary figures. So intra-alveolar pressure at the start of expiration plus 20, and watch it here, atmospheric pressure 0. So as the person starts expiration, the air starts coming out. The air starts coming out, and as the air starts flowing out from plus 20 to 0, atmospheric pressure 0, alveolar pressure plus 20. So obviously the air is going to flow from plus 20 up to 0. Now what happens is, as the air starts flowing out, as the air starts coming out with forceful expiration, there is gradual dissipation of pressure head. This is where I want you to imagine dissipation of pressure head as the air starts coming out, as the air starts flowing out with forceful expiration. So dissipation of pressure head means alveolar pressure is plus 20, then in the upper, as the air starts coming out, it will be plus 18, plus 16, plus 14, plus 10, plus 8, plus 6. At some point of your forceful expiration and at some point of your respiratory passage, the pressure has become plus 6, meaning the pressure inside and the pressure just outside, that is interstitial pressure, is both are now plus 6. So that point in the respiratory passage and that point during your expiration at which the pressure inside the airway and pressure just outside is equal, that point, उस point को कहते हैं equal pressure point. That point is called as the equal pressure point. Okay. Now what is the big deal about this? Big deal is beyond this point, beyond this equal pressure point, upward, the pressure is going to be plus 5, plus 4, plus 3, plus 2, plus 1, 0. So beyond this point upward, the pressure is going to be less. Pressure inside the airway is going to be less than the surrounding pressure, interstitial pressure. That means now you can imagine inside pressure is plus 5, plus 4, plus 3. Inside means inside the airway, pressure is plus 5, plus 4, plus 3, and outside the airway, interstitium, the pressure is plus 6. That means what? That means now the airways are prone for compression. The remaining part of expiration, the airways are prone to compression. Why? Because pressure inside the airway is less, plus 5, plus 3, plus 2. But pressure outside them is plus 6, that is greater. And therefore, they are prone for compression. Now, first thing, this type of compression has been called as dynamic compression of the airways. Why do we call it dynamic compression of the airways? Because it's not a steady pressure which is compressing. These are dynamic interactions between a changing pressure inside the airway and the changing dynamics of the lung volumes. And therefore, this has been called as a dynamic compression of the airways. Okay, so the concept of equal pressure point, and beyond that point, for the remaining part of the airway, there is a possibility of dynamic compression of the airways, because it's a dynamic interaction between the pressure inside the airway and pressure outside the airway and changing lung volume. All are changing, means pressure inside, then lung volume is changing, and therefore because of this dynamic interaction, it is called as dynamic compression of the airways. Now I am coming to the very, very, very important point, and that very important point is, in normal individuals, in healthy subjects, in healthy people, the equal pressure point occurs in first 7 generations. First 7 generations. Normally, in normal healthy people, the equal pressure point occurs in the first 7 generations. Now you tell me, think and tell me, what is there in the first 7 generations? What is there in the wall of the first 7 generations? Yes, you got it right. Cartilage. Yes. In the first 7 generations, the walls have cartilage. So imagine the airway is cartilaginous. So even if the pressure inside the airway is less and pressure just outside is more than that, there is a possibility of compression, but there is not much compression because those airways have cartilage. Those airways have cartilage. So I want you to take this concept at this point. Remember this concept. Yes, Pratyush Pradhan ji, thank you. At least somebody wrote, and you wrote it correctly, cartilage. First 7 generations have cartilage, and therefore they are not much prone for compression. They can exhale out almost normal. I mean, they can exhale out maximum amount of air. Beyond a certain point, they will reach only the residual volume. Well, so this is the concept of equal pressure point. A point in the respiratory passage where pressure inside the airway and pressure just outside, that is interstitial pressure of the lung. These two pressures are equal at that point. That means beyond that point, upward, we are talking about upward because we are talking about the expiration. That's why I'm talking about the upward. So beyond that point, upward, pressure inside airway will be less, and therefore it is prone for compression. It is called as dynamic compression of the airways, but normally this point comes in the cartilaginous airways, and therefore there is not much compression. You can imagine cartilage, semi-bone like structure, and therefore it holds the airway like that. It provides a tethering effect, so no compression. Okay, now having understood all this, now we will proceed further and let's check it out what happens in the COPD patients. I mentioned already that in health, equal pressure point is in the first 7 generations where there is cartilage, so there is not much of a problem during expiration. Now coming to the COPD, the most important part. So if any second year, third year students are attending this lecture or watching the video later on, they will understand why the COPD patients breathe in a certain way. Okay, so in COPD, check this, EPP is shifted to the lower 16 generations. Mark this point again. In COPD patients, chronic obstructive pulmonary diseases, where there is obstruction of the airways, because of the chronic obstruction to the airways, their breathing pattern is altered. They have to take forcible inspiration, forcible expiration. So because of an altered pattern of breathing, slowly, what happens is the narrowed airways and altered pattern of breathing causes the equal pressure point to shift downward, to shift towards the lower airways, to shift towards the non-cartilaginous airways. Now that's going to be a problem. Watch it. So noted the point, EPP shifted to lower 16 generations in the case of COPD. And why? I already told you, because of the changed structure, narrowed airways and changed pattern of breathing. So now the EPP has shifted to the lower airways, right? So what happens now is that the EPP reaches early during their expiration. Can you imagine this? See, the person starts forceful expiration. The person starts forceful expiration. Starting pressure inside the alveolus was plus 20. And now because the EPP has shifted downward, now this person starts exhalation and EPP has now shifted to the non-cartilaginous area, means lower airways. So it reaches early in the expiration. Early part of the expiration EPP has reached. It means what? It means, see, plus 20, plus 10, plus 8, plus 6. That's it. That means beyond that point upward, the pressure inside the airway is going to be less than the pressure outside. And that means there is going to be dynamic compression of the airways. Now this time it is in the non-cartilaginous areas. As we have said that EPP has shifted to the lower generations. That means non-cartilaginous airways. So now this person will be prone to severe dynamic compression of the airways during expiration. And why during expiration? I have already mentioned this, that okay, I didn't know ma'am is also attending. Hello ma'am. Asmita ma'am is attending our class. Thanks ma'am. She is a veteran physiologist, senior most teacher in Pune. So thanks ma'am. Those who are not aware, I just introduced ma'am. Okay, so now this equal pressure point reached early during expiration. See, why expiration? Abhishek, I have read already, and you can ask all these doubts later on, because this is a live stream. Later on you can join my Telegram group, and there you can ask thousands of doubts. I'll be happy to reply. Okay, my Telegram group, most of the students are aware, Vivek Sir's Physiology, same name. I'll send you the link. Okay, so during inspiration they don't face much of a problem. Now I'm talking about COPD. During inspiration, negative intrathoracic pressure will pull open the air. Okay, imagine that there is a negative intrathoracic pressure. So it will pull open the airways, even if the airways are narrowed, compressed, edematous, inflamed, by that negative intrathoracic pressure. But during expiration, this peculiar phenomenon will happen, and there will be severe dynamic compression of the airways, and the remainder part of expiration, expiration is going to be very heavy, very laborious, and they will have great difficulty for expiration. So please understand, this is what happens in the COPD patients, that the EPP shifts to the lower non-cartilaginous airways. Which means what? Which means ek to EPP, equal pressure point, reaches early during expiration, and then since it's in the non-cartilaginous airways, for most remaining part of the expiration, there will be heavy compression of the airways. Now there is no cartilage for many of these airways, so therefore they will have a very difficult expiration. So please note it down that in COPD patients like bronchial asthma, like chronic bronchitis and such conditions, inspiration is relatively easy because of the negative intrathoracic pressure during inspiration, but expiration is very difficult, and this is the main reason for that. That being said, now let's see how do they breathe. How do these people breathe? How they should be breathe? How COPD patients should be taught to breathe? How you should breathe? 3 points. They breathe, and while breathing they have to achieve these 3 points. These points should be inculcated. All right. Abhish, okay. Is equal pressure point same as critical closing pressure? No. Closing volume of the lung. Critical closing pressure is for the respiratory system, and probably, ma'am, you meant closing volume of the lung. No, that closing volume is present in everybody. Airways near the base, they begin to close because of the gravity, and that's present in everybody. Equal pressure point is also present in everybody, but it is different. It is at different places for different individuals depending on their breathing patterns. So it will that's why it is never said that equal pressure point lies in this particular exact point. It is said it lies somewhere in the first 7 generations. So slightly different. Even after equal pressure point is reached, breathing can continue. But when the closing volume of the lung is reached, then breathing can hardly continue, because beyond that point, most of the airways are closed, and therefore they are slightly different. EPP reaches first. The closing volume which you are referring to, ma'am, it reaches little later. It comes after that. Okay, so breathing in COPD. First point, inspire slow and deep. COPD patients should be asked to inspire slow and deep. Slow and deep inspiration. Slow and deep inspiration. What will be the fallout of that? Slow and deep inspiration would mean that deep forceful inspiration. More the forceful inspiration, more will be the negative intrathoracic pressure. You must have heard this, you must have read this, that more the deep inspiration, greater will be the negative intrathoracic pressure, and greater negative intrathoracic pressure will help open up the airways. Their airways, I am talking about COPD patients. COPD patients have narrowed airways, constricted airways. So if you create a deep forceful inspiration, I mean if you create a maximum negative intrathoracic pressure, that will pull open these airways. So their inspiration will become little easy. But because of that, because of the slow and deep inspiration, they reach near the higher lung volumes. You know, when we inspire maximally, the lungs are at higher lung volumes, means a lot of air is there. When we breathe out maximally, the lungs will be near the lower lung volumes. Less air will remain in the lungs. So higher volumes, lower volumes. They will breathe near the higher lung volumes. So first point to be noted is that COPD patients, they breathe slow and deep, particularly inspiration is slow and deep, so that they reach higher lung volumes near the TLC, total lung capacity, and they will mostly breathe in that range of volumes. Okay, they inspire slow and deep, creating negative intrathoracic pressure, great negative intrathoracic pressure that will help to pull open the airways, and airflow will become easy. Point number 1. This kind of inspiration, their lungs will go towards the higher lung volumes, towards the TLC, total lung capacity. Now the next part, they exhale also slow. I want all of you to now focus on this particular point, and that is they exhale slowly. Why? I'm sorry, the screen is flickering. There is some technical issue. I'll sort it out after the lecture. For the moment, please adjust to it. Okay, so they exhale slowly. How does it help? Look here. Remember the term dissipation of pressure head. Do you remember the term dissipation of pressure head? So imagine they have maximum inspiration, maximum forceful inspiration, and now they have started the exhalation. If the exhalation is rapid, the pressure head will also dissipate. You know that plus 20, plus 18, plus 16, plus 10, plus 8, plus 6. Pressure head is dissipating. If you exhale rapidly, rapid exhalation means rapid dissipation. Pressure head means plus 20, plus 10, plus 8, plus 6. That means equal pressure point early. Early means in the non-cartilaginous airways, lower airways. So what they are attempting is that they exhale slowly. Exhalation, the COPD patients exhale out slowly. Slow exhalation means what? Pressure head from plus 20 will be gradual. Pressure head dissipation of pressure head will be gradual, like plus 20, plus 19, plus 18, plus 16, plus 10, plus 8, plus 6. That means pressure point. Today there is a technical issue, I think, but this is the last 5 minutes, so just focus for this last 5 minutes. Some technical issue regarding the OBS. Anyways, so just focus now. They exhale slowly, but near the higher lung volumes, the COPD patients exhale slowly. So the pressure head plus 20 upward will be gradual. You have to imagine this. If the exhalation is rapid, if the rapid flow of air, pressure head will also dissipate very rapidly. Plus 20, plus 10, plus 6. That means equal pressure point will come near the lower airways only, in the cartilaginous airways. They are attempting to push the equal pressure point. These people, COPD patients, should be asked to breathe, exhale slowly. Equal pressure point shifts upward because head will dissipate gradually. Plus 20, plus 18, plus 16, plus 14, plus 10, plus 8, plus 6, like that. So this will push their EPP back towards the upper airways, towards the cartilaginous airways. And the third point, last point, so please bear with this technical glitch for now. Last point is they purse their lips. Last point, this is the pursing of the lips. I think I'll just explain this and then we will end this stream because there is too much of a glitching. Pursing of the lips. Listen to this part carefully. Last two sentences. They purse the lips. Pursing of the lips creates an artificial resistance at the outlet. I'm talking about expiration and pursing of the lips. They apply pressure from below. Means not like this, but by forceful expiration. So pressure is being applied from below and air is coming out from the mouth, but the pursing of the lips creates resistance at the outlet. So air starts with a lot of force from alveoli, but there is resistance at the outlet, at the mouth, because of the pursing of the lips done by the COPD. So what happens is air cannot come out easily. Air cannot come out easily because of the resistance at the outlet over here, and that means air applies a lot of pressure from inside while coming. Can you imagine this? Air is flowing out during expiration, forceful expiration, so a lot of force applied from at the lower end by the thoracic cage, but air cannot easily come out from at the other end. What will be the result? Air will come out very slow, for a very slow velocity, but a lot of force applied from inside. What happens is, because of that resistance at the outlet, air is coming out, it is applying force from inside and is trying to open up the airways. Can you imagine this? Force applied from lower end, but resistance at the outlet, and therefore air is coming out with applying lot of force from inside the airway and airways and coming out. So this is how it helps. I'm really sorry, my apologies for the technical glitches that have happened in this broadcast, but I hope most of the concepts were understandable, and I thank you all, particularly Fadke ma'am. Thanks a lot for attending. We have always been the great exchange. Always have the great exchange of intellectual thoughts and physiology concepts. So if you want to discuss anything, we will discuss. Thank you. Thanks a lot, guys. See you next week with another live broadcast, live stream or broadcast with another concept. All right. I just want to say this. Some people think, will I be able to understand the concept? I am constructing the broadcast, means that topic in such a way, तो ऐसे कि आपको पहले का और आगे का मालूम भी नहीं रहेगा, तब भी आप इंडिपेंडेंटली सुन के, सिर्फ ब्रॉडकास्ट सुन के भी आपको समझ में आएगा, और नॉट ओनली समझ में आएगा लेकिन आपका आंसर में भी वैल्यू एडिशन हो जाएगा. ओके, सो डू अटेंड. सी यू नेक्स्ट संडे फॉर द नेक्स्ट संडे लाइव, Sunday 5 physiology live. Let's deep dive. Yeah, thank you. Bye bye. Thanks ma'am. Abhishek, you can connect by Instagram, Telegram, everywhere. Just put the same ID, Vivek Sir's Physiology. This ID you will find on any social media platform. Yeah, thank you. Bye bye. See you next Sunday. Thanks.